Hi, Dr. Clancy. Thank you for joining us today.
Yeah, thank you. Thanks for having me.
So, you're a previous friend of Contagion, but for anyone new tuning in, could you refresh us on your background before the pandemic and your current involvement with the COVID-19 response?
Sure. I'm Chief of Infectious Diseases at the VA Pittsburgh Healthcare System. I'm Associate Chief of Infectious Diseases at the University of Pittsburgh. I'm an infectious diseases clinician and researcher. My research interests over time have been in molecular mycology and in molecular mechanisms of resistance among multi-drug resistant bacteria. And on the COVID front, I've been part of our institutional response in the VA Pittsburgh system to COVID. Working along with Dr. Brooke Decker, who's our head of infection prevention, who's taken the lead on sort of the institutional response. So, helping her with that, we have 7 facilities throughout southwestern Pennsylvania, joining parts of Ohio, West Virginia, and New York State. We have a long-term care facility that's part of the hospital. So, but a lot of preparatory measures that need to be taken and tailored to each of those sites. And then I've been primarily responsible for overseeing then our clinical service in-house and in the clinics as COVID has unfolded here. I will say that in Pittsburgh, we've been lucky. We really haven't been part of the big first wave of COVID in this country. And if you went back 3 or 4 weeks ago, and you said we'd have had the amount of disease that we've had up to this point, I think we would have been quite happy and we would have taken that. I suppose we've been lucky in that regard.
It's good to hear. I was actually wondering when you mentioned it, the different contexts having to apply different measures there. Can you just briefly touch on what kind of, for a long-term care facility, for example?
Yeah, right. Right. So we have a 200-bed long-term care facility. We have patients who would be sort of nursing home type patients, as well as patients who are there for long-term care needs. A lot of people getting chronic antibiotics, for example, or getting rehab. And Dr. Decker and her team within the infection prevention group here at VA Pittsburgh, I think, immediately identified this, going back to January, as the biggest vulnerability within our system. So we have 2 hospital campuses within the city of Pittsburgh itself. The long-term care facility sits on one of those campuses, so it's directly connected to the hospital itself. And we see a lot of traffic then between between the long-term care facility and that hospital, as well as our more acute care hospital across town. So that was our primary focus in terms of preparation. And then, of course, I think the in-house preparation was similar for hospitalized patients to what systems everywhere have had to do. Preparing and educating staff, making sure we were up on our PPE and our procedural steps for testing patients, moving patients. We stood up 2 units, an intensive care COVID unit, and then a more general medical floor COVID unit where we would admit and test patients. And like I said, we were prepared for a bigger rush than we ended up getting.
So on April 29th, I'm calling that Remdesivir day. We were hit with a lot of seemingly contradictory information. There may even be more information by the time this interview is published. And then not only that, we're sort of getting these bits and pieces rather than seeing the full picture.
Yeah,
so
yeah.
Could you go over the day's events a bit just to help differentiate the 3 results we're talking about for those who aren't familiar?
Yeah, it was a crazy day. So this week, I've actually not been on our physical in-house service. I've been manning the computers and doing some telemedicine and giving backup support to the services. So I've basically been in this office on the computer. So I was basically able to follow it online as it unfolded, and it was a crazy day. On my end, anyhow, the first thing I noticed, pretty much first thing in the morning, was the press release from Gilead, and there were 2 press releases, which created, I think, quite a bit of confusion. On the one hand, they alluded to the data from the SIMPLE study, which was the 5 versus 10 day comparison of remdesivir, not the placebo-controlled trial. And then later on, they alluded to what proved to be the ACT data, the NIAID data, which Dr. Fauci spoke about. So it took a while to sort out that, in fact, there were two different studies that were being alluded to. And as word of the press releases kind of circulated, and the allusion to the fact that the results looked promising for remdesivir, then you had kind of mid to late morning online at Lancet the publication of the Wang study out of China, 200 plus patients, which actually did not show any distinct benefit to remdesivir over placebo among patients admitted to hospital with hypoxia and relatively severe COVID. So on the one hand, you had the press releases touting the results from these studies that were going to be presented. And then on the other hand, the only published data we've had still to this point were basically a negative study out of China. And then midday, of course, as everyone was digesting the actual data in the Lancet study, you had the meeting at the White House where Dr. Fauci then spoke of, at least in general terms, the results of the ACT study, which was stopped early and which showed the now famous, reduction in symptoms from 15 to 11 days, and the trend toward decreased mortality with remdesivir in over 1,000 patients included in that study. So over the course of 4 hours that morning, you had 4 different reports coming out. The only complete data set remains the Lancet study data set out of China. And then the rest of the afternoon, you had all the parsing and media play and what have you that came with those reports in the morning. And yeah, I think you're right. I think we're still not 100% certain of where we stand and where precisely remdesivir is going to fit into the treatment strategies we might put together. And I think we're really going to need to see the nuts and bolts data out of ACT and out of Simple, before we get a better handle on
that. And even seeing the Lancet data, what I've heard, and that it sounds plausible to me, is that it's somewhat substantial that treatment was initiated later than a lot of people have been predicting would be good for or ideal for remdesivir usage.
Right. Yeah, I think in that study, you could be enrolled up to day 12, which is pretty late in the day. As it turned out, in that study, more patients were enrolled at a later time point in the remdesivir arm than in the placebo arm. So you could argue that, the deck was kind of stacked against remdesivir in that study, in that you'd hypothesize for an antiviral drug of this sort that the benefit would be biggest the earlier you got treatment on board with the drug. There was a non-significant numerical difference in shorter time to symptom resolution among patients who were treated earlier in that study with remdesivir. And in a sense, that was the same signal, you could argue, that came out in the ACT study, at least the extent to which we've seen the data up to this point, where, if given early, remdesivir may do something in terms of shortening symptoms. But, I think for the antiviral drugs, if they're going to have a role in treatment strategies, they're going to do their best job the earlier it's given. And that may be different from the anti-inflammatory strategies that are being talked about out there, which may help, a bit later in disease course as the immune response kicks in.
So there's going to be some interpretation here, but do you think that press release from Gilead about these good top-line Simple results, people have been saying it had something to do with counterbalancing the China study that was due to be unembargoed from the Lancet later that day. And it's noteworthy that Lancet released their information early, seemingly in response. And I'm just sort of wondering, in a more general sense, how do these kind of back and forths and the kind of unprecedented way science on this has become really injected into some of the culture wars in a very strange way. How does that affect what we're trying to do here with that big response?
It's crazy. Yeah, it's crazy. It's not the way science should be done or reported. It's not the way clinical trials should be done and reported. So I suspect that Gilead knew that the Lancet data were going to be dropping, so they got out ahead of it, and their press release said, "Hey, we're going to have these favorable results." And then Lancet got their stuff out, and it just created mass confusion. It created mass confusion among people who follow this. And then when you talk about presenting this to the, to the media or to the lay public, uh, you get even more confusion, and it's not helpful. And I think the way we have to view COVID is that we're in this for a year and a half. Spending the extra couple days, the extra week, the extra 2 weeks. I mean, peer review is happening pretty quickly right now. I think for the sake of a couple days, we have time to vet data, at least to some extent, and get it out there through somewhat controlled fashions and have something of an informed narrative. And, it's also not apparent really to me exactly what happened with the White House and with Dr. Fauci's announcement. At least one report I saw said they were worried, or he was worried about leaks, and he wanted to get it, in front of potential leaks. On the one hand, I think he was fairly moderate in what he said, and he certainly didn't call it a game changer. He didn't oversell it. I thought the press response afterwards was a bit muted. I was expecting things about, the mortality being blown up a bit, and that really didn't happen. But by the same token, he called it standard of care, and that's quite a powerful statement, particularly coming from him. And I presume he's had a chance to look at the data and feels confident enough to make that statement about the data. But these type of statements and just the extraordinary nature of almost casually tossing it out at a press gathering in a sit down in the Oval Office was quite extraordinary. And I think if you had told him 2 months earlier something like this would happen, he'd say, "Well, this is inappropriate. This is not the way we share our information." But there you have it. So crazy times we live in. And I suspect he wanted to get out there before the narrative got further distorted and twisted and further politicized.
Right. So I mean, it's sort of
have to wait for his book, right? He'll write a book, God willing, in 5 or 10 years, or whatever point he actually ends up retiring, and have all these fantastic stories going back 30 years, and maybe we'll really learn. But
the Fauci memoir is going to be fantastic if that.
Brad Pitt could play him, so
yeah. So how do we? I mean, you hinted at it a bit with what you were saying about we do have time to breathe. I mean, like it's urgent in a sense, but how do we kind of navigate all this data that's coming out very quickly? How can we cooperate in the most logical fashion?
Well, yeah, I mean, from the very start, right, with the whole sort of first Kaletra, and then in particular the whole insanity around hydrochloroquine. You had these stories out of Lombardy, you had these stories about New York City, and it's an unprecedented crisis, and people are dying, and we have no effective treatments. But by the same token, this is a long game, and I think from the very beginning we needed, as you said, let's take a breath, let's digest what we have, and over the course of 2 years, a week or two, is just not that big a deal, particularly if the advantage of that is getting things more right and knowing sooner rather than later. I also feel like what we really needed at kind of a federal level, as with much of this whole story in the U.S., is we needed just better sort of guidance and coordination. And this is something the federal government can actually do and actually does do. But better coordination within the United States and then internationally in coordinating these trials, making sure the priority was getting people enrolled in these trials so that we can get answers from these trials as quickly as possible. And, all that was missing. And I think we're seeing sort of the first steps now, 3.5 months into this entire thing at a federal level in the US, and trying to coordinate these things, right? So there's announcements now this week about, okay, let's see if we can expedite vaccine development and getting different bodies rowing in the same direction. So that's where we should have been. Hopefully it's where we can get, but I think it's really hurt not only the dissemination of information, but also the enrollment in clinical trials, getting clinical trials done and getting answers so that for the next, year, we actually know what we're doing as opposed to guessing about what we're doing.
Yes, and that vaccine acceleration effort did have a very Star Trek type name with Operation Warp Speed.
Yeah, and
I wonder sometimes who comes up with these.
well, it's pretty good though. And I think Dr. Fauci over the past day or so was saying, hey, maybe we can get some answers by January. I think one thing that's missing is appreciation, maybe on the part of the greater public, that you know you get to the point that you have data. The key though is going to be, once you get something that appears to work, can we upscale manufacturing? And that's the key, right? Putting together the mechanism so that then you're not starting the manufacturing game after you have the clinical trial data, but you're preparing for this. And this is, with warp speed, what they're trying to do. But again, this is something that the U.S. government can organize and coordinate. Ramping up testing, ramping up vaccine production, ramping up drug distribution. And it just seems to me, until relatively recently, we haven't done this on a coordinated national scale. And it's hurt us up to this point, and it's going to continue to hurt us. And, the testing is a prime example, unless we get it right. And again, this is something uniquely the government can and has done in the past. I think the most telling thing to me is if you look at South Korea, right, and famously now they had their first case diagnosed on the same day in January that we did. Within a week, on a coordinated national level, they had their company sitting down and scheming these things out and ramping these things up with diagnostic testing and what have you. And that's what we needed to be doing.
There were these targeted interventions. There was public health communication that was clear and simple,
and we have these playbooks. I mean, there's binders, Mitt Romney binders full of plans for these things. It was all written down, and then we just didn't enact them.
Right. I mean, the pandemic response hasn't been what governments planned to do in response to pandemics for decades.
And spoken about. I mean, you go to ID Week, for the past decade, every ID Week has a session devoted to this. And people lay out, this is what we're anticipating, which in a number of these scenarios was a novel coronavirus coming out of China. And it's remarkable how well these models actually, anticipated what would unfold, including, some of the more chaotic aspects of our response. But of course, the one thing none of the models considered was the fact that we wouldn't be able to get diagnostic testing up and running. So that was the biggest single failure we had. And again, the South Koreans had their biotech people in a room with government and with the appropriate public health agencies the first week scheming this out. And we didn't. And I'm still not certain that we've done it to the extent that we should nationally. But at this stage, we are where we are. So better late than never. But I guess the Koreans and a lot of the nations in Asia got burned to a greater extent, certainly, than we did with things like SARS and MERS, and I think they learned their lessons. And despite the lip service we did over the past decade, we seemingly did not learn lessons from that. We largely avoided the consequences then, and now we're paying it back when the big one has come.
Right. And I mean, even when it comes to the testing, there's a whole upstream and downstream issue with the diagnostics where we don't even have the necessary laboratory medical professionals to run some of these diagnostics, let alone having enough of them.
It's everything, right? It's everything from the original test development then to every aspect of actually getting tests done, data collected, and then disseminated, right? So it's not merely the test itself. That was sort of the original problem. It's all the reagents. It's the distribution of reagents. And then, as you say, it's the personnel to run them. And then you have to have an infrastructure to actually do something with the results.
Well,
I think that's lacking. And we would probably need an army of people, 150,000, 300,000 people nationwide, would be pulled into sort of a public health response force that could, as part of rolling out testing and systematically doing it, then take results, do the contact and tracing and everything that would be part of, a coherent national response. And what I worry is that with all this pressure now to open things up, that at some point we'll accept some tolerable level of disease and death and won't feel compelled to push beyond that. So I don't know what that threshold is, right? I mean, Nate Silver on 538, I think one of their podcasts, he was speculating, it may just be that if you had 300 to 400 deaths in the country a day, that's a low enough burden, particularly distributed throughout the country, that politically it could be acceptable to go along at that pace. And, I wonder if that's where, after all the sacrifices we've made for the past several weeks, that's where we end up as a country. We just say, you know what, it's just too hard to do much more than this, and we'll just accept whatever threshold is going to be acceptable for us until, the winter and flu season comes.
I mean, yeah. So we end up doing, social distancing for a few months, but then the follow through, those targeted interventions don't end up happening, and
No, and we
it
just sort
ends
of
up being
muddle
a waste. Not a waste exactly. I
through.
mean,
But you've asked unprecedented sacrifice of
yeah.
almost everyone in the country, as well as the whole of our economy, from the biggest corporations down to small shops.
And
These
that has a
sacrifices have
public
been
health
made.
effect too.
What's that?
That has a public health effect as well.
Well,
It's not
absolutely,
just COVID.
absolutely. I mean, what's happening to the 50% of patients who are not seen in clinic and hospital right now?
Yeah.
At VA Pittsburgh, all these heart and lung disease patients, they haven't disappeared. All the vascular problems we see, all the diabetic foot ulcers and osteomyelitis, we're not seeing them in the hospital right now, but they're not gone. So all these are indirect public health impact. But the point is, we've made these sacrifices. So it seems to me, having made these sacrifices and made that terrific investment of people's time, effort, anxiety, and the economic investment we've made, for the sake of just not doing the final bits to get it fully right and just accepting something less than we might have accomplished, I think then devalues all the work we've put into this point. And I just fear that that's where we'll end up, that, having done all this, we won't get the benefit that we might have gotten, and we'll have excess healthcare costs, excess death, and excess economic damage beyond what we were going to suffer anyhow.
Well, and I'm curious what you think needs to be done, particularly with nursing homes, because right now it seems like there's really very little coordination or systematic. I mean, I don't even think systematically we're doing temperature checks at the door, let alone,
Yeah, I mean this, and
limited
this,
testing resources.
this was so easily foreseen. Like I said, Dr. Decker and her infection prevention team here, when we were looking at vulnerabilities at VA Pittsburgh, one very small place in one particular part of the country, we instantly knew the nursing home was our biggest vulnerability. The first week of March, the first case we diagnosed at VA Pittsburgh was March 22nd. 2.5 weeks prior to that, the first week of March, we had a single entry and exit point to our nursing home. We had questionnaires and temperature screens on everyone in and out, and we were doing surveillance testing of patients to the extent that we were able at that point with test availability. So, we were able to figure it out. I don't. It's beyond me why someone at a federal level, at the end of January, wasn't sitting down and saying, nationwide, we've got a ton of people in closed communities who we can't get out. So nursing home patients, we're not going to be able to move them out of these high risk settings. We've got prison populations and these other, confined populations that are just going to be incredibly vulnerable. Let's start planning now. What are we going to do? What can we recommend? What guidance can we give to places to do? And things like these entry measures, screening measures, measures for directing testing toward employees and toward those vulnerable populations. All those could have and should have been pre-planned. So I would hope now, as we have more testing capacity, that we can get into these places and learn exactly what is happening. You're seeing those reports this week, right? I mean, these reports about 75% attack rates in certain federal prisons. The nursing home data, Southwestern PA, the state of Pennsylvania in general, has among the oldest populations in the country. And you're seeing these attack rates of greater than 50%. We need to go into every nursing home and survey and actually find out what's going on everywhere. And then from there, try to figure out on a center by center basis what needs to be done to try to mitigate the risk going forward. But again, the federal government is the actor that can bring that together, going to local counties and states, and this disjointed patchwork response is incredibly inefficient, and in the end is not as productive as a more coordinated, nationalized response would have been.
Right. And this is something a lot of people in ID and even elsewhere in the medical community, were like we said, talked about for decades before this happened. The specific measures that needed to be taken. There was the initial. I mean, I remember covering people talking about the vulnerability of nursing homes, and then on the political level, it seems that you know the emphasis was on looking serious.
Yeah, well, I mean, I think an awful lot of our federal response has been, more show than substance. Yeah, you could certainly argue that the press briefings have been more show than substance. Um, so we've paid the price, and I'm just worried that we'll continue to pay the price
Yeah.
moving forward.
So I'll just to wrap up, I'll just open the floor if there's anything about the response or remdesivir that you'd like to highlight for fellow ID folks. Anything other investigational therapeutics worth keeping an eye on? I'll just
Yeah, I mean, I think we need to take our time, get and digest the remdesivir data, look at it in the context of the published data out of Lancet, and then come up with sort of a coherent, rational strategy for how we think this drug is going to be best used. Um, let's say the data hold, and upon vetting, really you do get the signals that are, suggested by the press releases and the discussion that's happened up to this point. Then, it's a step forward. And it's encouraging, even if you didn't get to a significant p-value, even if my understanding is the p-value for the mortality difference in the two arms of the ACT study is on the order of 0.06. But let's say that was real. You went from 11% to 8% mortality with remdesivir given, relatively early in the disease course. So let's say you had, a number needed to treat of 30 to achieve some sort of mortality benefit for one life saved. Even in a place like Pittsburgh, where we've been, certainly not an epicenter and only had really the whole county, Allegheny County's had about 1,200 cases. I mean, you're talking at VA Pittsburgh, at the University of Pittsburgh Medical Center, even more so, you're talking a number of saved lives if 30 is the number to treat. So this would be a real advance, if not a complete and utter game changer. But of course, it's an IV drug, so it's not going to have anything out really in the community as far as utility goes. So we still need more. With the adaptive trial design in the NIAID ACT study, they'll be adding on now remdesivir versus remdesivir combined with an immune modulator. And it'll be interesting to see if these combined antiviral approaches, probably given early in disease, attacking the virus itself, combined with some sort of immunomodulatory strategy for mid to late term in the course of disease, can we get more incremental gain from where we are right now? I think the treatment strategy, we're probably in the end not going to get a game changer, but if we can get a series of incremental steps, that will improve things. And until such time as we get a workable vaccine that confers protection, or we get to natural infection herd immunity, a series of incremental steps might be the best we can hope for, but would be better than where we are right now.
Right, something is better than nothing.
Something's better than nothing. So let's get the trials done. Let's get people enrolled in the trials. I think a lesson from here is if you get real clinical trial data, then for the first time you can really begin to rationally discuss what should we be doing with drugs instead of just pulling hydroxychloroquine or something else off the shelf and throwing it at people. So maybe this will focus people's attention on the importance of, rather than giving them drugs out of study, let's get people in the studies, let's get definite answers, and then for the 95% of the U.S. population and world population that's not yet been exposed to this virus, going forward, we'll have answers for how to best treat them and ultimately how to best protect them.
Thanks for joining me, Dr. Clancy. Much
Yeah, terrific.
insights. And I'll talk to you again soon.
Yeah, and I'm checking out Tyrone Power there on the Marcus Zorro on your wall. So
Yes,
I'm
yes.
sure you're watching a lot of Netflix like all of us these days. And,
We're all in the same boat there. Yep.
yeah. Anyhow, hopefully we'll, when we chat down the road, things will be a bit different.